Hello, everybody. Good afternoon. Good afternoon. I know we're all warming up. We'll give you 3 more minutes and then we can start. Good to see you all. Good to see you all.
Good afternoon, all.
Good afternoon.
Good afternoon, everybody. Hello, good afternoon.
Good afternoon. Peace.
Recording in progress.
Okay, it's 4 p.m. Good evening, everyone. Thank you for joining in early, and a big hello to everyone joining across all our streaming platforms on Facebook and those joining over Zoom. Thank you for joining this session. It promises to be very, very educative. I'm glad you took our time to be here. You can share the link with other people who you know should be here so that they can also join us in this conversation. My name is Wemimo Adewuni. I'm a broadcaster and I'm your host today for this Endometriosis Hangout. It's a hangout, but it's an educational hangout. We have our panelists here who will be taking us through various conversations and topics on endometriosis. So if you have questions while we go ahead, please use the chat box and send us your questions. We'll have a session to receive questions from you. So use a chat box. When we also open up the floor for questions, if you'd like to ask one, please just raise your hand so that you'll be permitted to speak. That will be towards the end of the conversation. Again, welcome. We'll start right away with a welcome address from Dr. Abayomi Ajayi, who's the founder, Endometriosis Support Group in Nigeria. Dr. Ajayi, welcome.
Yes, thank you so much, Wemimo. It's great to see these great people here today who have made out time to be part of this. So I'll just go straight to my welcome address. Distinguished ladies and gentlemen, it is with great pleasure that I welcome you to the 2022 edition of our annual Endometriosis Awareness Month event. The SGN is joining with World Endomatch USA this year again. And we're focusing our attention on attracting government, especially on the African continent, starting from our own country, Nigeria. We would probably take some time to join the World Endomatch, especially when it is the turn of Nigeria. Maybe if you can spend a few minutes and see what we are presenting to the world, because we joined this since 2014, and on an annual basis, we've been joining them for this awareness. There's no doubt that government needs to take a significant interest in the condition with a view to ensuring that women get access to diagnosis and management of endometriosis, thereby improving the quality of life of people living with the condition. After all, we're talking about 10% of women of the female population. This year, we're taking a cue from the global theme, and I encouraging our people living with endometriosis to speak out. The global theme this year is speak out. Let us encourage one another, let us share experiences, and let us make our voices heard as a community to drive home our quest for access to care. ESDN has continued to be in the forefront of endometriosis advocacy and treatment in Nigeria. We've been giving subsidized and sometimes free treatment to some patients. We have concentrated a lot on secondary schools, the senior high schools, where we're doing a lot of advocacy, and also we organize annual essay competition amongst these young ladies for them to increase the awareness of endometriosis. We also have this almost like a pageant that we look out for the face of endometriosis in Nigeria, and that's also an annual event. But today, we're focusing our attention on 3 key areas of interest. We're looking at the diagnosis of endometriosis. What are the new things that are ongoing now to assist doctors make accurate diagnosis of the condition, especially in Africa, where we have very sparse modern equipment, and it's important for us to be able to promote how doctors can make the diagnosis of endometriosis, especially on time, so that we don't have the delay that's characteristic of diagnosis of endometriosis right now. Then we're going to look at the effect of endometriosis on the quality of life, and Dr. Oboro will be taking us on that, and then she's all the way from the UK, and I've listened to her talk a couple of times. I'm sure she will tell us a lot of good things and new things. And then Dr. Lawal will be taking us on the economic impact of endometriosis. Yes, I know she's a medical doctor, but she has an MBA, so she should be able to tell us about the economics of the disease that we're talking about. And of course, the big masquerade, who is going to give the keynote, Professor Chris Aimaku, who is representing Professor Adewale today. Prof is in Abuja. You know what that means. I'm not going to say more than that. He's on federal assignment. So we have great presenters from different geographical locations sharing their knowledge and experience with us today. I strongly believe that we're closer to where we ought to be in terms of getting the attention of our government to focus on this segment of our society. Like I said, these women with endometriosis represent about 10% of the female population, and that is very significant. And I think we cannot continue to ignore them or pay lip service to them. We need to be more structured in our approach to how to look after these women. So all I'll tell you is that today, please sit back, relax, and enjoy what I believe will give you more impetus to stay the course as we speak out on endometriosis. Thank you so very much.
Thank you very much, Dr. Ajayi. You've touched on quite a number of things, including some of the work that the Endometriosis Support Group Nigeria does. I love the advocacy targeting secondary school students, because it's important for them to understand what's going on with their bodies and seek help in time. 10% of women worldwide is quite a number. That's a significant number that we cannot wave away. So remember, for those who are just joining us, we'll have a session later on to take your questions as this conversation continues. So please feel free to make use of the chat box to drop your questions. We'll also open the floor for you to be able to speak later on if you can, if we have enough time. But at that time, you please be required to raise your hand to ask a question. Now let's go on to take our keynote address from Professor Isaac Adewale, who is an endo champion, good to know, and also the former Minister of Health. He's ably represented here by Professor Chris Amaku. Professor Amaku, welcome. Professor Amaku, can you hear me?
Yeah, I can hear you. Can you hear me?
Yes, I can hear you clearly.
Okay, thank you very much. Thank you so much for the introduction. I bring greetings from Professor I.F. Adewale, former Minister of Health, who is unavoidably absent. And 24 hours ago, he drafted me to be here. And when he does that, I really don't have any choice but to feel honored when a great man tells you to do something like this. I thank the Endometriosis Support Group for all you're doing. I also thank my hero and mentor, somebody who I learned a lot when I was a very junior doctor. He wouldn't know that because I was just a needle in a haystack, Dr. Abayomi Ajayi, for all you do. I mean, you have so much energy. I wonder where you get it from. And of course, you look so young all the time. And then the Endometriosis Month event, those of you that are watching right now. So good afternoon, everybody. I would like to declare that I have no personal interest in terms of trying to promote any group or NGO. This presentation is purely for academic and knowledge purposes. And I will try and make it as simple as possible, even though there's a keynote address, just to look at an overview of what we may want to talk about today. So I'll just mention a bit of some of the key facts which have been mentioned already by Dr. Ajayi, and then let's look at the health, social, and economic benefits of addressing endometriosis, which we're going to talk about, and then some current challenges and priorities. What are the key facts? Some of the things have already been mentioned. We know, yes, that endometriosis, the disease where similar tissue to the endometrial lining of the uterus grows outside the uterus. And this can be very traumatic because it causes a lot of pain. And sometimes patients present with infertility. It affects roughly about 10% of reproductive women globally and girls. And that's quite, like was said earlier by the moderator, this is quite a large amount of people. It is a chronic disease, usually associated with severe life-threatening pain during the periods, menstruation, dyspareunia or painful pain during sexual intercourse. And really what you get in terms of symptoms depends on where these tissues decide to, or where they go and propagate or develop. You can have urinary symptoms. Another distressing symptom is actually chronic pelvic pain. The patient keeps on complaining about pain and comes almost every time to you. And then they could be tired, and it could lead to depression, anxiety, and infertility. The variable and broad symptoms of endometriosis, you can see it involves almost all the organs, all the systems in the body. It makes it very difficult for health workers to easily diagnose. And that's why it's good we're going to have a session on diagnosis. And things have evolved and changed over so many years. Now we know that many individuals suffering from it may have limited awareness of the conditions. So they may be going from one health personnel to another, taking analgesics, and other things. And this can cause a lot of delays between onset of symptoms and diagnosis. At present, we know there is no known cure for endometriosis, and treatment is usually aimed at controlling symptoms. So access to early diagnosis and effective treatment is very important, because if you can't do that, then you will keep on, especially we keep on going around. And that's why we're going to address this today. So it's one of the things that we need to, patients or people suffering from it need to know. Because in limited settings like ours, where low socioeconomic status are poor countries, that means patients it'll take a longer time for them to get to where they can get proper care. So there's a need for more research and awareness raised about this issue, so that we can ensure effective prevention, early diagnosis, and improved management. And like the Endometriosis Support Group is doing, this will go a long way to achieve this. A little bit about the health, social, and economic benefits of addressing endometriosis. We know it has a significant social, public health, and economic implications. But many of the patients, not only are they sick, they or feel unwell, they don't feel like they are withdrawn sometimes. And of course, with a lot of money they spend going from one place to another, this can really affect them. It can cause decreased quality of life due to the symptoms they have, especially when they have severe pain, fatigue, depression, anxiety, and infertility. And then some individuals with endometriosis experience debilitating endometriosis-associated pain that prevents them from going to work or even going to school. I remember seeing a girl of about 20 or 21 suffering from it many years back. I mean, she just couldn't cope at all. And in these situations, and addressing the issue can reduce absence from school or increase an individual's ability to contribute to the workforce. Painful sexual intercourse is a very big problem, and it leads to the interruption or avoidance of intercourse. And many men will not understand why their wives don't want to participate in this activity. And it can affect the sexual health of affected individuals and even their partners. So this webinar is very good. It's called, and all the series of things that have been being done by the Endometriosis Support Group really is very important because it addresses endometriosis, and this will empower those affected by it. And by supporting their human rights to the highest standard of sexual and public health, it can increase their quality of life and overall give them a good well-being. Prevention, like I said, we'll talk, there's really no way to prevent it, but we know that enhanced awareness will do a lot for it. So just addressing some current challenges and priorities. We know that in general, in many countries, the general public and most frontline health workers providers are not aware about the pain and how to treat them, like I mentioned. Patients who could benefit from medical management are not always provided with treatment due to the limited awareness of the experience of the primary healthcare providers. I mentioned about delayed treatment. So in many countries, access in those patients where you need to have surgery, access to surgery is usually suboptimal. And in low and middle income countries where patients have to pay for their health, it's also a problem for them. And in many cases, we need to have multidisciplinary approach to these conditions. So I welcome you to these presentations you're going to listen to. And I hope you have a good time and you will learn a lot from it. Thank you very much.
Thank you very much, Professor Imaku. Thank you so much. You've again touched on very many important things, and I hope that our audience caught up on it. Interestingly, and very fortunately, we'll be having addresses regarding these issues, how endometriosis affects women in terms of they are being able to even show up at work. I remember that in a society where we're looking for more women getting into workspaces, into STEM, into what used to be men-dominated fields, this might be one of the biggest hindrances. So if you stay here long enough, we'd also have a conversation about the economic impacts of endometriosis. Now, the effects of endometriosis can sometimes maybe not be described just by looking at the word. So we're going to play you a video, and you'll see one of the sufferers of endometriosis who shares their experience, first-hand experience. This will give you an insight into what really happens in the daily life of a woman who suffers from endometriosis. So we'll play your video shortly. We'll take just a few minutes and then we'll come back to our next presentation.
I decided to talk about endometriosis using myself as an example. As a sufferer, I was diagnosed at the age of 15. That's when I found out that I had endometriosis. I haven't lived with it for years. Have I been able to cope with it? It has not been easy because it has affected my life. It has affected my relationship, my family. It has cost me a lot. Being a sufferer, I decided to use this medium to speak out, to encourage others out there. Coping with and living with endometriosis, I had to change my lifestyle, especially my food. I had to go through a strict diet, which consists of no sugar, low grains, more fiber. greens and water, and also my medications. I had to live with it, and I had to do more of lymphatic movement like yoga, which helped my body. I decided to use this medium to speak out today because I might be encouraging someone out there. I might be using my voice to create awareness so that the world will know that there is a chronic illness affecting women and we need a cure. I know you're out there. If you're watching this video, if you're listening, I want you to make 2 to 3 minutes video tagging Nordica Fertility Clinic, Endometriosis Africa, Endometriosis, and also post it on your Instagram, your Facebook, your WhatsApp, your Twitter. I want you to speak out today. Use your voice. Your voice is what gives you your right, gives you an advantage to fight. If you're watching, please share this video. God bless and have a lovely day.
So there you go. I mean, that says it. That says it. You can see, I mean, from her description, and I believe she really actually put up a bold front there. And that gives you a sneak peek into the life of a woman who suffers from endometriosis. Again, about 10% of women worldwide. It's argued back and forth. It's about 30 to 40% in Nigeria, the number of women who suffer from endometriosis. Now, as you heard, affects your total lifestyle. And that's why this is a very important conversation to have. We'll go on to our next presentation, and it's coming in from Dr. Loretta Ogboro Oko, who's a consultant of obstetrician and also gynecologist. She'll be speaking about the effects of endometriosis on the quality of life. Right. Oh, no, pardon me. Before she comes up, let's go on to Dr. Abayomi Ajayi to tell us about the diagnosis, right? We should know about the diagnosis before we move on to the quality of life. So Dr. Abayomi Ajayi will speak about the diagnosis of endometriosis. Tell us what's new. I mean, of course, over years, we might have found out new ways to handle this big health challenge. Dr. Abayomi is a convener of the Endometriosis Support Group in Nigeria and also the MD of the Nordica Fertility Centre. Dr. Ajayi. Dr. Ajayi, please, can you hear me? Is Dr. Ajayi still here?
Yes, I'm here. Sorry, just give me 1 minute. I think there is. Can you hear me?
Yes, sir, we can hear you now.
Fantastic. Okay, so maybe I'll just start there. So, diagnosis of endometriosis, what's new? That's my topic. Of course, like Professor Emakwu has defined it, it is a chronic inflammatory disorder characterized by the presence of endometrium-like tissue outside the uterus. I know sometimes some of us, when we talk as doctors, we tend to lose people because some people will be wondering what is the endometrium. Of course, the endometrium is the inner lining of the uterus, which is where I don't know whether you can see my cursor, which is what a woman sheds every month. Now, so you can imagine what we're talking about is that when this endometrium is misplaced or it has gone somewhere, it's gone away and it's somewhere else apart from where it should be. And we can see in this other diagram, we can see it here, it could be here, it could be on the ovary, it could be in the, well, this is what we call the broad ligament, it could be, and sometimes actually it could be outside completely after the pelvis. But so that is what happens, is that this endometrial tissue also behaves like the normal endometrium, which builds and breaks down and is like the woman is menstruating inside her abdomen or wherever this implant, as we call it, happens to be. Now, this is an estrogen-dependent condition. That is, it feeds on estrogen. Estrogen is the female hormone, and therefore that's why it's commoner in the reproductive age group. But that does not mean that the symptoms cannot really progress beyond the reproductive age group. So it's not impossible for some people to actually even have some of the pain after they've reached menopause, but that does not often happen. Well, the prevalence we don't really know, but we think is between 2 to 10% of women. But we have seen that it causes a lot of infertility. And so people quote between 30 to 50% of patients with infertility have endometriosis. Now, the National Institute of Clinical Excellence in the UK says it is the second most common gynecological condition in the United Kingdom, second only to fibroids. And therefore, we estimate that about 190 million girls, women worldwide have endometriosis. And that's why we cannot be quiet about this. A lot of women are silently suffering with this condition. And then as much as this is a problem, this condition is largely undiagnosed and undetected for many years. We heard the lady who gave the testimonial. She said it was discovered at 15. She was actually one of the lucky ones, because we will see some of the studies that we've done even locally. So it said all over the world that there's between 8 to 12 years void between when the symptoms start and when there is a diagnosis. Of course, during this period of time, the quality of life of sufferers is not spared. And like she said, it has cost her so many things, and that's what happens. It costs so many women, even their careers. There's so many careers that have been cut short because of endometriosis. So many homes have been scattered because of endometriosis, according to what Professor Amaku alluded to in his keynote. Now, what are the symptoms? And this is where the problem is. Sometimes there is no symptom at all. But for those who have symptoms, it's pain. Usually this pain now, that's where the problem also is. This pain is not, there is nothing that you can hold on to. It could be with menses, it could be without menses. So it could be there all the time, but sometimes it's worse with menses. And then you could have bleeding from abnormal sites, and then you could have infertility. Whatever these symptoms are, what they do really and truly is that they affect the partners and families, and therefore affect a lot of relationships. We did a 10-year study at the Nordica Fertility Centre to see patients with endometriosis who went through IVF. And what we saw was that the mean age of patients who presented was 34.1 years, so about 34 years. About 70% of these patients presented in the fourth decade of life, between 31 and 40 years. And that's why I said the person who gave the testimony, I was lucky that he was even diagnosed earlier. BMI 25.8, 66% of them had primary infertility, 61% of them, actually this is not severe endometriosis. And what we saw was that 73.8% of them presented with dysmenorrhea. And that's why one of the things that we're looking out for, which one of the studies we're trying to do, and that's why we focused on secondary schools, to see the incidence of dysmenorrhea in these young ladies, to be able to follow them up, to see which of them or how many of them will finally have endometriosis. But one thing that we found in Nigeria, which is not surprising, there is only 5% of them who had a positive family history, because in Nigeria, we don't tell people about diseases. So I'm not surprised that that is so. And then, why is this delay in diagnosis? That's the million-dollar question. We can see that the symptoms of endometriosis are varied and very broad. And some people say that because these symptoms are also private, I have pain when I have sex, that some women might not want to discuss it with their doctors, except when they understand the importance of the discussion. So we say that is a masquerade of a disease because it can present in so many ways, depending on where the implant is. Imagine the implant is in the chest. So it's not impossible for some women to be coughing out blood when they are menstruating. It's also not impossible for it to be in the brain. Rarely it does, but it's possible for it to be there. Then there's a lot of lack of awareness among caregivers and even sufferers. So many people have been asked to suck it up that after all, you're a lady, your sisters don't have this kind of pain. Why are you the only one having this kind of pain? And so we say that majority of them, some of the things that cause this delay again is this, what I refer to as the 3 M's. They are misdiagnosed, they are misunderstood, and therefore they are mistreated. Then one of the papers that I like so much is this paper by Eric Sori. Eric Sori is from Colorado. He runs the Colorado Center for Reproductive Medicine. And he looked at the impact of endometriosis diagnostic delays on healthcare resource utilization and cost. And he categorized the reason why endometriosis diagnosis is delayed into two parts. He said some patient-centered causes and some physician-centered causes. And the patient-centered causes, top on the list was embarrassment. Patients are embarrassed to discuss some of these problems. Some of them have been stigmatized and they've learned to live with this. Then some have become tolerant to these problems and they've just decided to live with it. And some even have become so uncertain of what is normal and what is abnormal, because everybody just tells them, they go to the doctor and the doctor says, you know what, I can't find anything wrong with you. Maybe it's in your head, you know. And then the physician-centered ones, the normalization of patient symptoms, you know. So many doctors have labeled patients as malingras, have labeled them as all kinds of, they've been asked to see psychiatrists, they've been asked to see all kinds of things. And then the fact that doctors also rely on inadequate diagnostic methods and clinical guidelines do not provide a constant approach to diagnosis. So those are some of the things. So how do we reduce this diagnostic delay? So that's what we're looking at. We're looking at, if we look at the patient-centered problems, that tells you that awareness is a major thing that we need to do. And that's why the month of March worldwide is regarded as Endometriosis Awareness Month. Actually, Nigeria also submitted, we've been doing that since 2014, we submitted our entry to the World Endo March, which if we are able to join, we'll see what we did. But one thing I want people to go out with, especially people who are not doctors, everybody should know that menstrual pain that disturbs your chores is not normal. Stop living with pains that are disturbing your chores. Go to the doctor. Do not let the doctor rest until they find out what the problem is, because this is probably, like you saw in the study we did, about 73% of them had dysmenorrhea, you know, which is menstrual pain. Then for the physicians, professional guidelines that are friendly are welcome. Simpler methods to diagnosis of endometriosis. And that prayer, I think, has been answered. And that's what we're talking about today. What is new in the diagnosis of endometriosis? Prior to 2022, this body called ESHRI, or the European Society for Human Reproduction and Embryology, and almost other professional bodies believe that laparoscopy is the gold standard for the diagnosis of endometriosis. And this made it very difficult, especially for us practicing in low resource areas. What is the percentage of hospitals that have laparoscopy? So it was so difficult to make diagnosis of endometriosis except in specialized centers. But now this has been taken off for the first time this year. I'm reading straight from the recommendation of ESHRI. Laparoscopy is no longer the diagnostic gold standard and is now only recommended in patients with negative imaging results and or where empirical treatment was unsuccessful or inappropriate. I'm going to tell you what that means. Let's just go on. So how then do we diagnose endometriosis? What should we be talking about? So I'd like to say that we should go back to the basics. So this concept of clinical endometriosis is what we've been trying to develop here. I'm going to share with you something that we submitted in October last year, which was published in February this year. So the history taking is really very important to the clinician. And that is one thing that almost every doctor can do, okay? But we need to pay attention to this, more to this history taking. So cyclical or non-cyclical pains and symptoms of dysmenorrhea, deep dyspareunia, dysuria, dyschezia, painful rectal bleeding or hematuria we should not just ignore it. You know, what used to happen was that you see many patients, they come to the doctor. They complain of these things that the doctor cannot put together. Oh, I'm bleeding when I go to toilet. When I'm trying to pass feces, I'm bleeding. Or I'm trying to pass urine, I'm bleeding. It only happens maybe for a week in a month. But the doctor never, ever asks for the last menstrual period. And that's probably most of the time is what clinches this diagnosis, that sometimes is related to the menstrual period. It's happening at the same time that the doctor, that the lady is actually bleeding from her normal menses. And also sometimes they tell you that we have shoulder pain, cough, which brings out blood. I've seen patients that have been on treatment for tuberculosis for about 2 years, and all they had was endometriosis or chest pain, or sometimes some people even tell you that they had surgery sometimes ago, maybe a cesarean section, and the wound starts bleeding at a particular time of the month. But the doctor cannot just relate it to the menstrual period, And so it's important for us to go back. When I was training as a young doctor, as a gynecologist, one of the first things we were taught is that always think ectopic. When a woman has not seen a menstrual period, she's bleeding abnormally, irregularly, always think ectopic. And that is what I'm going to leave also doctors with, that you must always think endometriosis, and that is the only way that you can have a high index of suspicion and be able to guide your patients properly. Sometimes it throws some other things like fatigue or infertility at you. I'm not going to talk about the diary because this is still something that people are debating. Now, the examination of the patient, that's why I say it's back to the basics. Examination of the patient. The vaginal examination is important where possible. Okay, because why I say where possible is that because there's some people, you probably will not be able to do this in a person that is still a virgin. So, but when the person is not a virgin, a vaginal examination is not, it's very, very important because you might just be able to feel the nodules, you might be able to feel the fixed retroverted uterus, and this might tell you, or you might be able to feel endometrioma or ovarian cyst, and this might be all things that will make you to increase your suspicion of endometriosis. Now, whether this is right or whether you find anything suspicious in your examination or not, if you have started thinking of endometriosis, the next thing you should do, you should ask for ultrasound. Imaging is important. And in this kind of environment, I'm going to talk more of ultrasound than MRI, but MRI, it's very, very important when it is available. And that's most of the time now in my center, I think we do a lot of MRI, but I'm sure not everybody will be that fortunate. If you are in the hinterland, especially somewhere in Nigeria, you might not be able to do MRI. But what we need to probably focus more on, which is one of the things I want to take away from here, is that we're going to increase training in ultrasound for doctors. And you don't need to be a gynecologist to be able to do that. MBBS is enough for you to be able to train in use of ultrasound. And like I said, if it's possible, you can also do MRI. Now, let me go back. I said whether your clinical examination was normal or not, you will need, it's better for you to do the imaging. So because sometimes when doctors examine and they say, no, I want you to go and do an ultrasound, some patients will say, why are you asking me to do ultrasound? So you must be able to explain to the patient, I'm thinking it could be endometriosis and I want you to do this. Because sometimes if you have endometriosis and the ultrasound scan can pick up endometrioma, which is with these high resolution scanners that we have now, then that's just is the end of the diagnosis. You can go and then either the doctor is going to refer you for treatment in a suitable place. One thing I want to say is that biomarkers are not established now in the diagnosis of endometriosis. So asking for biomarkers, it's probably not on now. So all your CA125, VEGF, or CA 19-9, they're not really found to be very useful in the diagnosis of endometriosis. Now, but this is one thing I want us to talk about, the empirical treatment of. This started a few years ago and everybody condemned it and then it died. But now we have brought it back to the fore that when your ultrasound, you have taken a history, you have suspicion, you've done your ultrasound, you've done your clinical examination, you are not still convinced that there's anything, you've done your ultrasound, you are still not convinced of anything, but the patient has pain. I think that's one thing we need to, you cannot wish pain away. And a good doctor, really and truly, how you relieve pain is what shows you that you are a good doctor. So no doctor should ignore pain. So this now is back that we can treat empirically. And this actually started with when we started understanding that adolescents, actually, that endometriosis starts in the adolescents. And that's why we're looking a lot at the secondary schools, senior secondary schools, so that when they start having a lot of dysmenorrhea, you know that I'm sure for the ladies, there's some people who you can remember in your secondary school that anytime they're menstruating, everything comes to a halt. Then these are people that you need to sometimes use the empirical treatment for, you know. And so when who are the people who qualify for empirical treatment? When you have history suggestive of endometriosis, there's dysmenorrhea, there's dyspareunia, if the person has started having sex, or there are other pains that you cannot explain. You have done your examination, that doesn't seem to be any obvious sign. You have done your imaging, everything appears to be okay. Then this kind of patients, and what do we do with empirical treatment? You know, what we do is you can give. I hate because we can give drugs like I would say oral contraceptive pills. I'm always careful when I'm talking in a webinar that it's not anybody can listen to. So I don't want to be accused of promoting self-prescription. So, but you can combine oral contraceptives can be used together with non-steroidal anti-inflammatory agent. For the doctors, that makes sense, I'm sure. You can use it for 3 months, and then if there is relief, you are likely to be dealing with endometriosis. If there is no relief, then that is when laparoscopy now is needed. And so that's what I'm just going to go to now. So laparoscopy, the guideline development group recommends that laparoscopic identification or laparoscopy should only be done to confirm endometriosis. Although negative histology, you know, for a long time we were fighting over histology, you must confirm by histology, but now everybody understands that you might not even have histology identification. Especially in a country like Nigeria. You know what I keep telling people when we're talking about endometriosis and so on and so forth? I keep telling them that if we continue training the physicians, the gynecologists, and we do not train the people in the laboratory, the pathologists, we continue to miss a lot of endometriosis because you give them a sample, they really cannot process it because they are not even thinking of that. And so the good news for me is this next statement that says that both diagnostic laparoscopy and imaging combined with empirical treatment can be considered in women suspected of endometriosis. So it's not until you do laparoscopy now. And I must always say that diagnostic laparoscopy just to diagnose endometriosis should not be done in 2022. You must be doing laparoscopy with the aim of treating. So what I'm saying now is that about 80% of patients can be diagnosed using history taking, clinical examination, imaging, and empirical treatment. So you have about 20% that will need laparoscopy, and this can be now referred to the big boys who have what it takes for the diagnosis and treatment to be made. Yeah, this is what I was saying. We published this paper, we submitted it for publication in October, though it was just published in February on the concept of clinical endometriosis, a paradigm shift in Africa. And I think this is one of the things I want us to go out with, that a lot of endometriosis can be diagnosed now clinically, not until we do laparoscopy. And that is one thing that's what I mean by what is the new thing. Laparoscopy no longer is gold standard, and histological confirmation is recommended, but not compulsory anymore. So primary care physicians can make a diagnosis of endometriosis now or have a heightened suspicion. So what are the implications of these new things? Diagnosis no longer an exclusive preserve of the super specialist, as primary care physicians can suspect and even diagnose endometriosis. Management and surgery can then be initiated earlier. You know, one of the things we've always been saying is that endometriosis is diagnosed very late at appropriate centers, possibly avoiding some of the complications associated with delay. The impact of these new changes are likely to be a long way in affecting the general physical, mental, and social well-being of the endometriosis community, especially in Africa and other resource-constrained settings. So this, I think, is good news for those of us who are in places where laparoscopy is not easily accessible, so we do not have to say we cannot make the diagnosis of endometriosis because we do not have laparoscopy anymore. We can have a very heightened suspicion of endometriosis, and then also we can, depends on what the complaint is. With pain, we can relieve the pain. If it is for infertility, we know where to send them to. If it's the drugs are not active with the pain, we know where to send them to. So we can act as gatekeepers to the treatment of infertility, of endometriosis in 2022. Thank you so much for listening.
Thank you very much, Dr. Ajayi. Thank you so much. You've touched on, so much. I have my paper full. I hope people are also writing and paying attention. I have my paper full. And one of the things you've touched on, which I think is one of the challenges, is the societal idea of women being strong. You know, sometimes you even have fellow women, you have mothers say, oh, why are you being like that? Like you mentioned, your sisters were not like that. So why are you the only one? The keynote to what you said is, don't get too familiar with pain. Check the source of every pain. It might just be something you need to check. And if you have a woman or a girl around you who's always complaining of pain, let it be checked out thoroughly. Thank you very much, sir. We'll now go on to our next presentation, looking at the effect of endometriosis on the quality of life. I'm itching for this one too. Dr. Loretta Ogboro is a consultant obstetrician and gynecologist, and she'll take us in this session. Dr. Oko, your microphone is muted.
Am I fine now?
Yes, you are. Welcome.
Well done, everybody. Good evening. Can we see my screen?
Yes, we can.
Thank you very much. So my name is Loretta Oduwari-Ogboro. I'm currently in the UK. Actually, I live across borders now, both UK and in Nigeria. Background, public health, clinical education, simulation, obstetrics, gynecology, and PhD law and criminology, specifically interest in trafficking. I want to say a big thank you to the panelists thus far. Professor Christopher Imaku, who is representing our Eastwell Minister for Health, and Dr. Ajayi himself, as well as you, Emo. You set the pace and put everything into perspective. You've really made my job easier. Endometriosis, we've defined it thus far, but I just want us to think about it a bit in very simple terms. That's abnormal, that odd one out. So if you have the womb, if you think of the womb like a cup and you turn it upside down, inside of it, there's a nice lining in there that responds to the hormones and the brain interplay every month. And it is the lining of that inside cup that sheds out. Now, just imagine that lining is somewhere else within the pelvis or within the body. And that means that every month, when the brain tells that lining to bleed or shed, blood is then lost into those areas where it should not be. A lot of them are small areas. And endometriosis does not, it does not have a formula. It varies from woman to woman. Its symptoms, it comes with pain, yes, but some women don't have pain, and we've all been talking about the 10%, 170 million to between 190 million worldwide is estimated. So where does it happen? I've told us that it can be within the pelvis, so the womb itself or the muscle of the womb, in which case it will be called adenomyosis, and then the ovaries, endometrioma, and then it can just happen in places where, like the lungs and old cesarean section scars, and interestingly, my mom told me a story. She said when she was growing up, there was someone around her whose hands used to get very painful and very red every month. My mom is 73 right now. And I asked her, so what did you people do? She said, well, they took her to the village native doctor to find out what sort of god or goddess was disturbing her or what was causing that. And I said, Mommy, that must have been endometriosis. I wasn't there, but I could make that diagnosis, which settles down nicely into what Dr. Ajayi has said. History, history, history. Let's speak out. On an average, we are told that the time people spend in circulation, the time women spend going from one care provider to the other is just appalling. Even in the United Kingdom, we've got an average of about 8 years. And in the US, you have 12 years. Norwegians have been adjudged to be a bit better, about 6.7 years. Now, in the Nigerian perspective, where culturally we have myths and taboos and sociocultural perception of menstruation that is like, oh, don't talk about anything below the neck. Don't talk about anything around the waist. People don't have these conversations. Mothers in the house watching, how many of you talk to your daughters or their teenage years about the concept of menstruation? Big sisters, mentors, how many of us? And if you look at the sociocultural milieu in the United Kingdom and the US, for instance, where people talk out and they communicate, and you see these figures of 8 years, 12 years, I am so worried about the Nigerian figure. And I went searching. I saw some quoted 30 to 40% burden. And I saw a study of about 8.1% in Kanu by, I think it was Adamu et al. And it's a recent one, 2020. But I really doubt those studies because being a researcher myself and somebody who is very keen on qualitative research, I can tell you that our sociocultural milieu is such that we are all guessing. So that brings us to the words of the representative of the minister. We need to champion these researches. We need to champion them as individuals. We need to champion them as establishments. Kudos to Nordica. We need to champion them as local governments, state governments, federal governments, universities. We need to champion all of these. So what is quality of life? Now we know what endometriosis is. We understand the body. What would one define as quality of life? If I say, oh, you have got good quality of life, what do I mean? There are many different definitions of quality of life. The WHO defines it as an individual's perception of their position in life in the context of their culture. Now, I want us to take note of this. Even the WHO is telling you that this is within the context of your culture, your value system, where you live, in relation to your goals and aspirations in life, your expectations, and the standards that concern you. So in effect, even though we are using the word quality of life, and I'm glad that we do have a health economist in the house. I'll leave that side to her, but I'll touch on it a bit because I did those studies as well. We all talk about quality of life, but it's a broad concept and it's difficult to measure. What may be positive to Wemimo may not be the positive to a Loretta. And so what did people now decide to do? People said, okay, let us sort of look at it across domains. And when I say domains, they're looking at your happiness, your psychological well-being, your physical well-being. And don't forget that WHO has many years ago described health as not just being a state of lack of disease, but a state of physical, mental, psychological well-being. So holistic. So it therefore means that measuring quality of life must be something that we do with a balance. And there is somebody's definition that even though it is old, I still use, and that is Cummings. Cummings said in 1992 that the concept of quality of life is an objective assessment of life conditions and a subjective assessment of satisfaction. So that means objectively, I can come and say, oh my God, this woman lives in a ghetto. But subjectively, that woman may be happy in her ghetto. And then there's another woman who lives in a mansion, but subjectively, she may be in pain and she may have poor quality of life. But somebody else looking will say, oh, this woman has a brand new car, she drives a Hummer, she looks good, she has proper quality of life. So we must understand this concept within individual places and their particular domains. And over time, despite the difficulties of measuring quality of life and the subjectivity that can come with it, people have worked hard to develop questionnaires, surveys, scales, and I can tell us that as far back as 1994, there were already over 150 tools and scales for measuring quality of life. You had the different ones. I'm not going to go into them. And I'm glad we have an economist in the house. But the WHO one, World Health Organization Quality of Life Instrument from 2012, looking at physical health, psychological health, your level of independence, your social relationships in the environment, spiritual, religion, and personal beliefs. So if you get up in the morning and you are not able to sweep your house, there is a compromise to your quality of life already. So somebody may come and say that I have an amputated leg. Everybody sees it. So they think I cannot sweep my house. They know, just looking at me, that my quality of life is impaired. But if I've got endometriosis and nobody can see that physical deformity, it then becomes a bit difficult and challenging to objectively create the facts and create evidence that I have got problems with my quality of life, irrespective of the scale we are using to measure it. And talking about quality of life and how endometriosis affects it, I have tagged it the endo effect, the effect of endometriosis. And the effect of endometriosis is relevant to all of us. Let nobody listening to me today in this program or on the live streams or that will listen to it later begin to think that, oh, they are talking about endometriosis. It doesn't affect me. No, that's wrong. Because if you have a sister who suffers with severe pain, who suffers with infertility, some of the things that have been mentioned on the short term, on the long term, you will become affected. If you have a wife, you will become affected. If you have a mother, you will become affected. And even your friends, you will become affected. So at individual, family, and community levels, subnational or state government and national level, we are all affected by these endo effects. You know, the physical and pathological, the Dr. Ajayi has taken on that. The psychological and emotional. When you are a schoolgirl, I went to a boarding house, Federal Government Girls College, Benin. I remember clearly people who I could tell you when it was their period. They didn't need to talk. They would just miss classes. Some will even miss exams. Name it. Even in churches, watch out those choir members that don't turn up on particular times. They are not just wanting to stay at home. They have not backslided like some judgmental people in the church would say. They may just have endometriosis. So I've said that the endo effect is like a value chain. A value chain is like a production factory where you have many items arising from one product. For instance, oil palm now, you can make oil from it, you can make kernel, you can make this. Endometriosis is the same. But the problem is that the byproducts are all negative. They are negative because you are going to have pain. You are going to have not just pain that debilitates you, but pain that affects intercourse. You are going to have infertility. You're going to have all the many things spoken about. The most common symptoms are on the screen for us to see. And sometimes it doesn't go alone, depending on where it is. If it's on the bowel, sometimes you are going to have eating disorders. You are going to have some people who would see blood when they go and poo-poo at certain times of the month because they have endometriosis that is in the rectum.
Dr. Oko, I am sorry, but I need to interrupt you for a bit. We'll come back to complete your presentation. We need to join the World Virtual Endo Match, which is currently ongoing. We'll just join for a few minutes so we can see presentations from other countries, just for a few minutes, and then we'll come back to take the other part of Dr. Oko's presentation. So stay here with us, and we'll see your chats, those softwares who have sent us messages. If you hang around enough, we'll possibly take some comments from you before we go. So let's join the World Endo March virtually now.
Let me stop my sharing.
Some people refer to Nigeria as the giant of Africa. Some people actually even say Nigeria is a sleeping giant. One thing about big animals that sleep, like the elephant, when they do wake up, they run very fast and go very far.
The country is right to take its rightful place as a leading nation globally.
We are going to take control of Africa, there's no doubt about that. And then we are going to confront the world.
Hello, members of the endometriosis world. Welcome to 2022. And on behalf of the Endometriosis Support Group Nigeria, I'm going to spend the next few minutes going over our 2021 review. 2021 was a very eventful year for everyone, with COVID-19 taking center stage all over the world. Despite the easing of restrictions in many countries, the world had fully embraced the new normal, a very significant shift in the way we live, work, and play. The fact that we were experiencing a global pandemic of unbelievable dimensions did not deter us from propagating awareness about endometriosis. Right from the beginning of the year, it was all activity filled. In January, we announced an annual secondary school essay competition, which had become a major tool for driving awareness about endometriosis among high school girls. In February, our Face of Endometriosis Nigeria and brand ambassador commenced a campaign aimed at getting women living with endometriosis to come out and speak out as part of our initiative to host a Sisters Converge event slated for the International Women's Day. Our key objective for the Endometriosis Awareness Month in March was to get more professional bodies and especially the government to begin to focus more attention on the condition. We are all aware that despite the debilitating effect of endometriosis on women, it has not attracted the attention of governments, especially in Africa. We want to be able to drive awareness in government circles with a view to effective policy formulation to drive research, diagnosis, and treatment of women living with endometriosis. To this effect, we were able to attract the attention of the Lagos State First Lady, the wife of the Executive Governor of Lagos State. Lagos State is the commercial capital of Nigeria. Her Excellency Dr. Ibijoke Sanwo-Olu was part of the event. After the event, we were able to meet with her, and she made some commitments to be a champion for endometriosis awareness in Nigeria. To top the icing on the cake, we held another virtual event on the 28th of March 2021 to celebrate World Endo March Day, which was a huge success. I would like you to sit back and watch clips from some of our activities for the year.
Did you know that 10 to 15% of women suffer from endometriosis? And these women are within their reproductive age. Yes, one of its many symptoms is painful menstruation, and this hinders the life of its victims. Sadly, a lot of people still do not know about endometriosis and still suffer in silence. In view of this, we are looking for honest and inspirational stories about the trials and successes of endometriosis in Nigeria. Remember, if you send in your story to us, you just might be inspiring other women and young girls living with endometriosis in Nigeria. Now, we really want to hear your story because we need to hear from you. Send us a 3-minute video of your endo story in Nigeria.
So you're all welcome to the Sisters Converge, an endometriosis conversation. And of course, Dr. Abayomi Ajayi, who is the founder of the Endometriosis Support Group in Nigeria. You're all very welcome, and happy International Women's Day to the women here in the house. Thank you all for making time, because I know today's a day we should all, sit back, relax, and enjoy the day, but this is part of it, having this conversation. So you're all very welcome. We will begin with a welcome address by the founder, Dr. Abayomi. And so we would, I'll mute my mic and say, Dr. Abayomi, I'm throwing this baton over to you.
So, well, thank you so much for joining us on good evening, good afternoon, good morning, whatever part of the world you are joining us today. On behalf of ESDN, I welcome all of us, the First Lady of the State of Aquatic Splendor, our own Lagos State Dr. Mrs. Ibijoke Sanwo-Olu, who is a medical doctor, and she has just received the message that she'll be joining us later on. Professor Isaac Folorunso Adewale, former Minister of Health of the Federal Republic of Nigeria. And every one of us that has created time, just like it said, you could have been doing some other things to join us on this webinar. Themes: Sisters Converge and Endometriosis Conversation. Ladies and gentlemen, it's the month of March again, and therefore it is Endometriosis Awareness Month. Today being the 8th of March, it is an important date set aside to celebrate women. I doubt if there's a better day to discuss an issue that has remained an enigma, an invisible, incurable disorder affecting the lives of about 176 million women and girls globally.
I would like to, I'll move forward up until when we have our other guests come through. So we would like to call on Professor Isaac Adewale, who's an endo champion and also the former Minister of Health.
All right, welcome back. So I hope you enjoyed that. We just took a short trip to join the virtual Endo Match. It's live on YouTube, so you can always watch a replay across the world. Every country is pitching in Endo supporters, speaking up today about all the activities to raise awareness about endometriosis across the world. So luckily we caught on when Nigeria was presenting, and Dr. Ajayi, as we could see there. So we return to Dr. Oko to finish up with our presentation on the effects of endometriosis on the quality of life. Dr. Oko, please.
Thank you, and well done for that presentation. That was looking very, very good, Dr. Ajayi and team. So where did we leave off? We left off, we're talking about the commonest symptoms. So I want us, we all have said, and every person has said so far, to get ready to do a very, very simple maths and actually bring this closer home, because I have kept this really, really simple because of the women, the non-doctors, these Nigerian patients, especially the women who are really worth it. Let's do a bit of mathematics. Let's see. So we've said that 1 in 10 women of reproductive age probably would have endometriosis. That's an accepted figure, evidence-based everywhere. So imagine if you're an employer of labor, or if you run a school, and employer of labor, you have 20 workers. So 2 out of those 20 workers will have endometriosis. If you had 30 children or 30 adolescents in a class, and it's an all-girls school, 3 of them would have endometriosis in that class. Now, we have periods as women when they are regular, in a 28-day cycle, it probably will last for 3 to 5 days. So if I take a mean from that, a mean, by a mean, I mean an average. 3 plus 5 is 8, divide that by 2, and I have 4. So it means that every month for about 4 days, because it can be more, just before the start of the period, worse as the period gets on and then begins to settle after the period. But let's use this average, and we say 4 times 12 months in a year. We're going to have 28 days for 1 woman. For 2 women, 48 days. So 48 days on an average, they'll be out of action for no fault of theirs, but that they are women and that they have a condition called endometriosis, which is disrupting their quality of life. So if you're an employer, in that year, you are going to have at least 48 days from 2 of your staff with very reduced productivity. And this may carry on a lot more, because don't forget the psychological effect. If you are a student, you are going to have, in that class of 30, you now have to multiply by 3. So you are going to have even more. So are you a surgeon? Are you a seamstress? Are you a singer, or are you a soldier? Are you a senator and here you are a woman? It shows you how we can all be affected on the individual level and as an establishment or in whatever we do. As a surgeon, if you had to operate on another person and you have crippling pain, how are you going to do a laparoscopy? And if you are in resource-rich nations where your productivity is monitored, how is that going to look on you? In a world where we already know that it's a man's world, whether we like it or not, and that's what we are trying to change. When we say speak out, when we say break the bias, you know. So the simple day-to-day activity is gone. School run, we can't do. Cooking, we can't do. We can't have sex. Sexual health is one of the most important reasons why I see women walk into my clinics. And some of them from Black and ethnic minorities, even here in the United Kingdom, come in and sit and watch you. And you are saying, oh, so why are you here? You are here because, and then they start pointing. They're not even saying the word, I have pain during intercourse. They are pointing down there. So even though they've left the shores of Nigeria, the social cultural milieu in which they were formed or in which we have been formed has not left us. And don't think a market woman does not suffer endometriosis. She will just as much as a senator in the hallowed chambers would. So at the national level, I'm glad our economist is going to tell us, but you can see how the GDP will be affected. At the subnational level and globally, everything is affected. So what do we do? Now we know that this endo effect affects our quality of life. What do we do? How do we reverse the endo effect? How do we reverse the effect of endometriosis on the quality of life? Sadly, we've all said that it's not preventable. That's what the evidence base is saying. What do we do? And I say the answer is in the team. 60% of the answer is in the team for this year. Speak out. Speak out and speak out and speak out. There is lack of research, like I've said, and the barriers that prevent health seeking. How do these contrast with the factors that are going to push people to seek help? What essentially is the health seeking behavior of our women in Nigeria compared to their counterparts elsewhere? And this is what led to myself and a colleague doing studies in endometriosis. First of all, done and presented in the European College and Board of Obstetrics and Gynecology in 2014, and then updated in 2019. It was simple, our findings. And the first thing is concealment, concealment, concealment. Even in the United Kingdom, people have an etiquette of silence, and femininity and social roles are still talked about in hush-hush tones. How do we break this? We need to start talking, and that's what we are doing here right now. People feel lonely in their illnesses. They feel ashamed. They don't talk about things down there. And this is somebody in the United Kingdom. How do you think we, who our mothers used to tell that don't touch that boy, you get pregnant? And I used to wonder, is pregnancy now a tactile transmission? We need to give the right information. And this is why I am so pleased hearing that we are targeting the adolescents in the schools, doing the essays, because we need to give out information. Today, I am best friends to a lot of my friends' children because I'm more like their agony aunt. There's nothing they cannot tell me. I'm not shocked, maybe being a gynecologist. I'm not shocked. I am not judgmental. I don't say, oh, no, it's not important. I give them all the support and I listen. The next thing we found in our work, which was a qualitative work, was the trivialization of symptoms. And I think Dr. Ajayi himself mentioned this. The gatekeepers. In the UK, for instance, the GP wants to save money. They are not quite keen to send you to the specialists. In resource poor nations like Nigeria, you don't even know who the specialist is. The ENT is treating gynecological problems. The nurse is running a betting center. You know, it's all jumbled up. But what you find is that people then tell you, oh, are you the first person to menstruate? Get up and go and wash those plates. Or like when I was in Federal Benin, you find some senior girls come in and say, why are you touching it? And you're like, oh, I have pain. Like, so? And then they are stigmatized. So find out from yourself, your doctor may not help you. And part of reversing this is also facing the uncertainty. These women, they are tired of the delays. The physicians have the knowledge, but like Dr. Ajayi pointed out, there's no use clicking a woman and you're not picking up the telltale signs. A woman turned up one day in my office and said, I always have pain on my old cesarean section scar. Immediately, I started thinking, cesarean scar line endometriosis. I gave her a diary, something as simple as a chart. And every month, she charted that it was more painful and more swollen. And then we just task shift. Oh, go to another doctor. Maybe another doctor will give you hysterectomy, but I am not keen. I don't think your problems are that bad. And then we are controlling these women. We are not really rendering the social support they should be getting. We are now making them to also take control because they are now going to have to do self-advocacy. And like Dr. Ajayi said, please do not stop. Go and seek help. If one person doesn't, there's something called second opinion. If women think they are alone in a fight, then they should take it up. We have the burden, as much as the physicians, to return or reverse the endo effect as it affects our quality of life. So at all levels, I was smiling when I saw the use of the word paradigm shifts earlier on. But at all levels, we do need a paradigm shift. In the individuals, we need a paradigm shift. Our lifestyle needs to change. Our health-seeking behavior also needs to change. It's not the time to keep quiet. We need to speak out and to the right people. You cannot take cyclical monthly pain to your pastor. He's going to pray, yes, but his prayer is something that should lead you to a capable person or a specialist, a gynecologist, to help solve the problem. You cannot take your painful sexual intercourse to your imam. There are people who specialize in talking about these things. And we shouldn't, I always talk about cultural integration. We should take the good things from other culture, merge it to our good culture, and discard what is bad. And I think communication is key. As Africans, we keep mute. Culture says when you talk about anything that has to do with menstruation is a taboo, but sex is a problem. But we have sex. We do. You come to England, you see two people holding hands, walking on the streets, but they may not have had sex. You go to Nigeria, people are not holding hands, yet they have 4 children. How did they do it? At the family level, we need awareness and support. So those mothers, when your daughter comes and says, my period is on, actually, she doesn't need to say anything. You will notice that at certain times of the year, of the month, that particular child is not gingering and swaggering, as we would say. No, she's just dull. She can't move. She can't do what she even loves. It's not the time to say, go and pound their yam. What's wrong with you? But it's the time to sit down and seek help. Take them to the right specialists. This is why this awareness is key. The groups and the NGOs, awareness. Communities and social cultural groups, awareness. Subnational governments, state governments, what are your budgets for health? Is there anything you can do into budgeting with the universities to research endometriosis in our own population? We shouldn't be depending on information from other people. Nobody's going to come and do our own work for us. At national level, when I look at the budget for health, it gives me headache. And even women's health and reproductive health. Because if you do not tackle what the problem is, then you're going to bear the burden. And the burden is impaired quality of life, impaired productivity in one of your greatest workforce population. So, to end my talk today on endometriosis, I will say to people, it is not a myth that this pain that destabilizes women, there are many women who are lucky as well, they don't have any problems, but there are a few who would have these problems. It's not a myth, and they are not pretending. Pain, unfortunately, is not properly able to measure it. It does affect their quality of life, and the quality of life measurement itself is also a challenge, like I pointed out. But every month you see some women who can't make school run. Think about them. And in terms of solutions, we need to look out for each other, raise the awareness, keep talking, keep seeking solutions within our own individualized social cultural concepts. Thank you very much, everybody.
Many thanks, Dr. Oko. Thank you so much for that presentation. And again, you've hit it all on the head. I mean, when you ask the question, people are not holding hands. Where did the babies come from? I had a big laugh, because yes, as Africans, we are silent about a number of things because these are cultural practices of the hush hush. Unfortunately, this hush hush attitude also affects health issues that are then swept under the carpet until possibly there are complications. So thank you very much for that session. Again, we'll be taking questions after the last presentation. So if you do have questions, kindly send them into the chat box. Okay, yeah, I think she has done that now. All right, we're going to our next and final presentation, by no means the least, because now we're going to talk about the money aspect. You've heard the numbers, right? We're going to speak about the economic impact of endometriosis. Dr. Bilkisu Kankai-Lawal is a consultant, obstetrician, and gynecologist, and she takes us on this presentation. Dr. Lawal.
Good evening, everybody.
Good evening.
I'm standing on existing protocols. I'm Dr. Bilkis Kankai-Lawal from Ahmad Bello, a consultant in Ahmad Bello University in Hospital Zaria. And a point of correction to Dr. Loretta, I'm not a health economist. I'm a gynecologist with special interest in endometriosis. So I'll be taking us on the economic impact of endometriosis. And like we've all seen, the great affectation to millions and millions of women, adolescents, women of reproductive age group, with an effect of about 10%. And when we look at infertility, this can be increased to 30 to 50%. Endometriosis, as we've seen, has great impact on the quality of life in all its aspects. The economic burden of endometriosis should, however, not be underestimated to the individuals and the society as a whole. So despite the clinical burden and its affectation on the quality of life, the economic impact is less well understood and has been less documented. So when we talk of the economic burden of endometriosis, it has been likened to high burdens of other chronic diseases such as the heart diseases, diabetes, and when we talk of the pain, to rheumatoid arthritis. So in that attempt, the World Endometriosis Research Foundation developed an EndoCost Consortium developed a tool that aimed to analyze the cost of illness impact. And from the economic perspective, this can be classified as the direct healthcare costs, the direct non-healthcare costs, then the indirect costs, which is mainly as a result of productivity loss. So looking at the direct healthcare costs, what constitutes this? we've seen the various delays from time of presentation to time of diagnosis. So as such, these women have a lot of doctor's visits because of the chronic pain or the menstrual irregularities. They're bound to various hospitalizations. And notwithstanding, to make diagnosis is really challenging. Looking at the imagings, which are expensive, if we talk of the cost of some surgical techniques like the laparoscopy, they could be unbearable, especially in the low and middle income countries. Then the medical approach, a lot of NSAIDs over the counter due to delay in diagnosis. Then we have other GnRH analogs, which are unreachable for a quite number of people. Then surgeries, which accounts for a significant percentage increases to the direct healthcare burden, be it the ablative, excisional procedures or hysterectomies. They are quite expensive. So the endo cost study in 2012 gave an estimate of more than 3,000 euros per woman per year that is lost to endometriosis. And this accounts for 95% of total direct costs. In another study by Amor et al., the average cost per person per year is over $2,000. So when we come to the non-health related costs, transportation to the various health centers to seek for help, accommodation, some have to move from remote settings to where they can access such healthcare. And most of the times in low resource settings is in the tertiary centers, so which are far from the populace. Then you have to talk of the feeding of the sufferer, the feeding to the carer. Then comes the carer cost, because who do you leave the household during the times of, who attends to the household chores? Somebody has to do that, and it has to be paid for. Then while in the hospital too, somebody has to take care of the sufferers. So also adding to the cost of endometriosis. So from studies, this cost has been found to be 5% of the total direct cost due to endometriosis. So the indirect cost is being looked at in terms of productivity loss. And this constitutes the major cost related to endometriosis. And we have these women within the reproductive age group. They also constitute a great significant part of the workforce. And the productivity cost has been found to affect the 84% of the total cost, which is 2 to 3 times higher than the direct cost of endometriosis. Okay, this is a study, an Australian national study that was done to assess the impact of the cost of illness for endometriosis. And we can see that 84% is as a result of productivity loss. And when we talk of productivity, we talk of it in terms of absenteeism and presenteeism. So when we talk of presenteeism, that's reduced production at work. The woman might be able to go to work, probably because she has taken a lot of her leave due to the pain, and finds it mandatory for her to go so as not to lose out. But definitely her production is going to be affected. Then in some cases, absenteeism, total absence from work or school for our adolescents. And this is mostly related to pain. So how does this loss of productivity affect the women? They have loss of chance for promotion, loss of earned income, because some workers might decide to reduce the cost for the sufferers if they don't present at work. Some could have their employment terminated, or even school. It could lead to school, and they could withdraw from schools, and some on their own accord could resign due to the stress of bearing with the pain of endometriosis. So we have an estimate of about 10 hours per week loss to productivity. This is from the Global Study of Women Health 2011. And this amounted to about $250 per week loss. And a study by Inoham et al. In 2011, which is a multi-center study, inclusive of Nigeria. Amongst those that were employed, endometriosis-associated productivity loss was estimated to be $208. So we know with the inflation rate, how this will translate to the economy of Nigeria. Pelvic pain and severity of endometriosis have been found to be the main factors that affect productivity loss. So the total average cost per person per year estimated to be more than $20,000. And there is significant relationship between the overall cost with increased severity of pain. When women have a minimal pain, and severe pain, there is a six-fold rise in the overall cost. And this translates to a twofold increase in health-related costs. And the productivity cost, which amounts for the total burden of cost for endometriosis, is about 12.5-fold rise. Okay. From the same Australian study, we have the total minimal pain of about $3,000 and over $23,000 in severe pains. This study done by Simeons et al. Is one of the largest studies that aimed to assess the cause of illness for endometriosis. And it's a multi-center, multi-country study that involved about 10 countries, European countries, the UK, and USA. And the study came about to determine the impact, and due to the lack of data we have, and the cost implication for endometriosis. And from the same study, we can see that for the direct health cost, surgery is the highest, which is about 29%. Then we have other costs that are due to monitoring or follow-up, 19%, hospitalization, 18%, and physicians' visits with medications accounting for the others. The total economic burden of endometriosis per year in the Australian study, with population estimate of 4.8 million, is estimated to be about $6.5 billion. So what is our reproductive age in Nigeria? What is our economic burden? We have to look at that. The annual economic burden of endometriosis has also been found to be substantially increasing over time, from 22 billion to 69.4 billion as at 2009. And now if we're to do the analysis, then we can only hazard a guess as to what it's going to be. So what are the factors that affect cost? We've talked about the length of time between the onset of symptoms and diagnosis. Could this be linked to lack of awareness? So many patients are undiagnosed, misdiagnosed, like we've seen. Severity and frequency of pain also worsens the cost affectation. And when there is associated infertility, these tend to also increase. Poor quality of life. Quality of life has been found to be the most important predictor of total cost and healthcare cost. There is no known cure for treatment, and the treatment is mainly symptomatic management. So patients have to be on and off clinics, on and off emergency presentations, hospitalizations, which increase to the burden of cost. There is lack of social support systems, socially, culturally, religiously. We've heard the presentation by Dr. Loretta, where people shy away from that. And some people fail to recognize that their colleagues are in pain and need support. Then the healthcare system. Most of the studies on cost are in settings where there are organized health insurance, with health costs received at subsidized rate. So we ask ourselves, what happens in the low and middle income countries where out-of-pocket payment is the mainstay? So what are our priorities to reducing the economic burden for endometriosis? Awareness, awareness, awareness can never be overemphasized. So we have to raise awareness among healthcare providers to make prompt and correct diagnosis. And the populace, the adolescents, women, men, teachers, we have to go to the grassroots at national and international levels. So I'm happy with the Endometriosis Support Group Nigeria that are making move to improve the awareness on endometriosis. And this could make a significant paradigm shift in Nigeria's approach to this debilitating disease. Training of healthcare workers on competency and skills to screen and diagnose and manage or refer in cases that are beyond the capacities, especially this should come down to as low as the primary healthcare settings. We have to advocate for health policies that ensure access to minimum treatment and support. Priority should be given to pain control, which has been found to be the most significant contributor to cost. Studies have found that when the pain is reduced by more than 10%, there is significant reduction in productivity costs and improvement in quality of life. Setting up of referral systems and careway pathways should not be overlooked. We have to strengthen the capacity of health systems for early diagnosis, management, then the issue of health insurance. At the community level, state level, federal government level, it should be emphasized. There should be increased research outputs and accelerate global collaboration to improve access to reproductive health. So in terms of research, in this cost analysis depends on epidemiological studies. So, and they differ based on the prevalence of endometriosis. So when we have accurate epidemiological studies to ascertain the true prevalence of endometriosis, we could have longitudinal studies as follow-up that aim to determine the economic impacts that will guide our policymakers. And this should be needed, it should be available at national and international levels to decrease the economic burden of endometriosis. So in conclusion, we've seen that endometriosis affects the aspects of women's life throughout, and we have to have a multidisciplinary vision that includes not only the medical approach with advancements in treatment, but also look at the psychological impact, the work environment, and economic support for endometriosis. In societies where healthcare costs and limited resources are of increasing concerns, like here in Nigeria, the public policy makers and healthcare payers need to pay close attention to the costs of endometriosis. Assessing the economic impact of endometriosis to individuals and society will help guide policy and our healthcare prioritization. We have to support the sufferers of endometriosis. Thank you very much. These are some of my references. Thank you.
Many thanks, Dr. Lawal. Thank you so much. I mean, when you mention all that amount of money, I'm here, just doing my calculation. And again, while we talk about the impact, companies are also doing the same calculations, and they're possibly then deciding to employ less women, because if you could if you could be losing so many days and so much amount of money, fewer women would be getting, jobs. And in the jobs that they do get, fewer women will be able to show up to actually do their jobs. So this is a very critical conversation to have. Thank you very much for that presentation. Okay, we have a few more minutes before we wrap up. We'll go on straight to our question and answer panel discussion, and then we'll also take some of your questions. I see a few. We have a question and answer box in the, if you look below your screen, you can drop your questions there. We'll also see if we can bring in one of those who have left us messages about being sufferers of endometriosis, if they could briefly share their points. All right, let me take a few questions. And I'm starting with Professor Amaku. You spoke in your presentation about frontline workers in diagnosis, and I think this is a thread that cut across all our conversations. Early detection, like Dr. Ajayi said, think endometriosis. That's to healthcare workers. How do you think we can improve on this? You know, in making sure that doctors pay attention and not just discard, the pain when, I mean, possibly they do not understand it. If you could give me a response in about 1 minute thereabouts.
Thank you very much. Thanks for your question, and thanks to everybody for their presentations. Well, like Dr. Jai said, he said we need to train more people to understand the disease, the symptoms, and not just to let patients just suffer. He said we should think endometriosis, especially when patients present with these symptoms, some of these symptoms that we mentioned. The woman is in the reproductive age group, and she has symptoms that are associated with her periods, then we must think endometriosis. I think it's better if more people are aware of this. I mean, when we're in med school, and indeed now, we find out that endometriosis is one of those topics that people don't really listen to. It's one of those topics that people just look at and say, oh, there are more interesting things like to talk about, like fibroids or cancer, etc. So people don't get to really hear much about it. But with this kind of support group going on for patients and people becoming more and more aware, I think more people will learn to appreciate it. And like he also said, we don't have to wait to have a laparoscopy now. Because before, people will not label a patient with endometriosis unless you have done a laparoscopy. How many people have access to laparoscopy? But now, once you suspect that, then you can always think endometriosis. Thank you very much.
Thank you very much for that. Dr. Lawal, I'm coming to you with all that figures you put up there for us. And I like that you mentioned most Nigerians pay out of pocket for healthcare. That's a big challenge. I mean, and you possibly see some of these patients on a regular basis. So particularly for women who are not in the urban areas, who have to travel out, you've told us the cost, accommodation, feeding, carer for the people at home. It's all a huge burden. I think it's a good time to make a call for health coverage for endometriosis. What do you think, Dr. Lawal?
Yes, looking at the economic burden in low resource setting, we don't have significant data to back that up. So, and we have to call this a call to the government to help in making the cost the barest minimum, or have access to insurance policies. And at the government level, even community level, the community can, with the awareness, rising in awareness, the community can come together and come with a community insurance, because the cost is really unbearable. Talking about the medications for pain relief, hospitalization, then added when there is infertility. It may really be bothersome, but we have to know our true picture of the burden of endometriosis, and our prevalence. We have to have an estimate of that. It will help us in such policies for costs analysis.
Thank you very much, Dr. Lawal. Dr. Ajayi, I'm coming to you now. Please help me understand. For women who have endometriosis, can it be cured, or are we speaking about lifelong management? Because it sounds scary to me that anyone has to deal with this for the rest of their lives.
Yes, thank you so much. Unfortunately, it's a lifelong thing because endometriosis has no cure. And that's why we're talking about it. The only thing we probably can do is to easily or quickly make the diagnosis so that you can even make some decisions. If you want to freeze your eggs, freeze, because it affects fertility. So there's so many things attached to this. But I think one of the things that we have all said is the quality of your life, So, and one of the things, if you understand what's wrong with you, your problem is probably half solved. So, yeah, so I think it's the diagnosis that we can early diagnosis.
Early diagnosis. I mean, that's what does it. Now, Dr. Oko, effect on relationships. You mentioned that briefly, and I can only imagine how this affects marriage and sexual relationships. Now, do you see more men getting to understand, I mean, what women are going through, and how can we carry men along? Because that will possibly make it easier to manage, family and love relationships if the men truly understand. Do you see men coming along with women in the clinics, to find out what the problem is, and when diagnosed, do they care, and how do we make them care?
Thank you. And many thanks, Dr. Lawal, for pointing out my error with respect to your role. Thank you, Wemimo. Directly to your question. You said, how can we carry more men along? The truth is, does anybody really want to be carried? Do people want to leave their comfort zones as human beings? We don't. So the key to getting the buy-in of any other person is to make them actually understand in simple terms how this affects them too. So if I cannot have sex with my husband, he needs to first of all realize that the truth is that it is not as though I don't want to have sex, but I cannot have sex. The pain is excruciating. And I'll tell you what a very simple thing a patient of mine did once. She actually told her husband to put his hand on the table, and she started stabbing him with a tiny penknife. Now, that may be extreme, but what she said was that she wanted him to actually understand the kind of stabbing pain she has every time during her periods. And after that incident, the man started coming with her to the clinics. He then then understood the meaning of more foreplay with his wife, unlike other women. He understood that they needed to get water-based lubricants to help in the bedroom. And then he began to then see her in a different light. Now, I'm not saying we should go to extremes like that, but what I am trying to say is that we must communicate. I find a lot of women sometimes, they are frowning and you're saying, what's wrong? My husband is not even looking at me. Does he not know that I'm not feeling fine? No, the brains of men are not wired like the brains of women. Please, my fellow women, my adolescent girls, begin to speak up. Have this discussion with your mothers. Have this discussion with your fathers. And I always say that if there is anybody who can change the life of a girl child, it is the father.
Thank you. Thank you very much, Dr. Oko. So I'll be taking a few of the questions and bouncing them around as we go along. We have a question here. Okay, I'll just read it out. It says, in as much as endometriosis is associated with some infertility risk, is endometriosis possible in a fertile woman within the reproductive age group? This person goes on to say her typical symptom is current dysmenorrhea, and right lower abdominal pain in a para 3 woman. Those are quite medical terms, but I'm sure you all understand. In a para 3 woman, 39 years of age, TBS showed normal ovaries and uterus. So does this look like a typical endometriosis case? Professor Maku?
Yes. Hello, can you hear me?
Yes, I can hear.
Yes, like endometriosis presents with so many different ways, and it depends really on where the abnormal tissue is, or where the tissue is situated outside the uterus. And these are some of the ways they do present. Like what you said. I mean, when I read it, I was like, oh yeah, this is what you see with a lot of few of these patients. So yes, that's one way they can present. And like has been said by most of the speakers, there are other ways you can also present with. but pain can be in any parts of the body where the tissues are. Thank you.
Thank you very much. Fatima Wakili Farouk also has a question here. Says, I've been diagnosed with endometriosis in 2010. I have a lot to voice out, but I'll start with a few. Number one, most statistics show 10% of women probably have endometriosis. Is it an extrapolation from foreign studies, or do we have a national study? Is there a specialist in endometriosis or infertility anywhere in Nigeria? Well, Nordica Centre is one. Dr. Jai, this is coming on your table. She's asking, do we have a localized study? I believe Nordica has done a study which he mentioned earlier. Yeah, Dr. Jai, take it up, please.
Yeah, thank you. Well, one is always careful about citing studies that we have done in a corner. I mean, it's better that it's a population-based study, because our studies are always skewed in the sense that we only see patients with infertility, so it's already biased. So, but it's interesting because that's one of the things we want to do now. And I guess in the next couple of years, we've been trying to raise funds to do that, to actually go to the community and see what the prevalence will be in the community. But these figures are estimates, and they're usually from other parts of the world. So yeah, for fertility, of course. I think that's what dragged me to all this. You know, we started this endometriosis since 2005. It's funny because when I started, doctors, journalists, nobody could pronounce endometriosis, the word. Maybe that's your endo something. You know? But now I think we've gone a long way, and I think, yeah, then we can always help with the infertility.
Yes, that's brilliant. So let me one more. I mean, I don't know where this person is asking this question from. So I know that in Lagos it's easy to access Nordica Centre, but do you think that across Nigeria in more local centers is it easy to access fertility care, possibly at general hospitals? Could that be a starting point?
Well, I don't know. Depends. I mean, teaching hospitals probably will help you better because I don't know the level of care in the general hospitals, but I guess teaching hospitals might be more like it. But of course, fertility is something that there are specialized centers for. So.
Yes. Okay, let me take another one. Okay, thank you, Frank Ezugu, Professor Frank Ezugu is saying, how often does this interaction hold? I think he has thoroughly enjoyed himself. Well, this is in commemoration of World Endometriosis Day, and the awareness is in the month of March, right? So, but since there is the Endometriosis Support Group Nigeria, I think you might want to, we'll talk about how you can follow that support group, you know, to have continued conversations. Zainab Kwaru Muhammad Idris, my question is, how do we get other healthcare workers other than doctors to develop capacity for identifying and possibly managing cases of endometriosis, especially given the task shifting and task sharing policy that we currently have? How do we also get management of the condition incorporated into our health insurance and contributory healthcare schemes? Zainab Kwaru, thank you. So for the task shifting and task sharing policy, I want to expect that the doctors here understand that. Dr. Lawal, could you help with that?
Thank you very much for that. So when we talk about the tax shifting, that's the whole essence of raising awareness. So we have to involve people at the primary healthcare setting to also be aware of how to make diagnoses, how to make referrals for that. And the nurses are part of and parcel of that, the psychologists, because it has significant psychological impact. We have to go to the to the community at home, teachers, and like the school program Dr. Abayomi is talking about, to make the people themselves realize support at the community levels. So, and tax shifting is really, really important in the management of this long-lasting, debilitating disease.
Thank you very much. I'm in the chat box now. I have a few interesting comments here. Raymond Patricia Victoria says she's actually joining from a hospital bed in Ejigbo, Idimu, Lagos, Southwest Nigeria. She says it's her second attendance and she's a sufferer of endometriosis. She's possibly in hospital for that. We'll see if we can get her to, if she's still here, to join us to share her experience. Patricia, are you here? Do you want to speak for a minute? We'll check at the back end to see if we can get her on for 1 minute. Another one here. Oh, she's raising her hand already. Okay, please raise your hand, Patricia, so that we can see you and can permit you to speak. So if you get there, Victoria, please just raise your hand and then you'll be permitted to speak. Okay, we have another one here. If there's a group help for sufferers, I need it critically. This is, oh yeah, the same Patricia. Okay. Nena Di Hedima is also a sufferer joining us. I don't know where from, but we also hope that you're able to join. So if either of you are still here and you'd like to speak for a minute each, kindly raise your hand. Just press the raise hand button so that way it's easy to find you and we can permit you to speak. Okay, I'm scrolling through the chat box now. Okay, we got this, Dr. Zena Poirot, your question has been answered. And I think, yeah. Habiba Bala says, early diagnosis is paramount. I observed pains around my umbilicus when I was around 30 years, but my doctors didn't suspect endo until about years later when my umbilicus started to bleed during menses. I am nulliparous. You would know what that means. I don't know what it means.
That means no children yet.
Okay. Okay. One more word into my vocab. Only manage sex as a marital obligation, but the pains have subsided now that I'm approaching menopause. That's quite a big one. Bill, yeah, okay, Dr. Bill Case is replying here. Do we have, oh yes, we have Patricia now. Patricia?
Hi, Wamimo.
Hello, how are you feeling? Hope you're much better today.
Good evening,
Good evening.
panelists. Good evening. I stand on existing protocols. Special recognition to Dr. Abayomi Ajayi. Dr. Abayomi, battle rages honor. I'm still there. So right now, I'm undergoing treatment of the bloody fluid from my stomach. It's been excruciating. Past few since Thursday, I've been here in Ejigbo, and I have no words. I was looking forward to this webinar because I really would like to sound suffering from endometriosis, sufferers of endometriosis who can afford these expensive treatments. Please, if the wife of the governor is listening and everybody who can help, please set up a place where we can come together as, sufferers to discuss and find solutions to this problem. It's really draining. It takes away everything from you. You have no quality of life. Since 2018, I've been in and out of hospitals. My job has stopped. My studies have stopped. Everything that I knew has come to a halt. I can barely even stand on my own. I can't bathe myself without losing breath. Wemimo, this is going to take much more than just once in a year or once in a while radio show. We're going to have to do much more awareness programs because I suffered it from when I was 14. secondary school, I saw classmates slump at the assembly ground. So what was said on this webinar was true. People faint and stay away from school, from studies for over a week, and then just lose that week before they are able to come back from home. So thank you for this opportunity. I know we don't have time.
Thank you very much,
I would
Patricia.
appreciate if my
Thank you very much for speaking out. Speaking out is a big deal, and I really wish you good health. We also have Nenadi Hedima, who sent a message earlier. Nenadi, are you there?
Yes, good evening all. I'm here and very glad to be part of this meeting. So could I go on?
Yes, please.
Okay. So I've been a sufferer for years now, over a decade. I'm approaching 45. By August, I'll be 45. And I think it first came to light when I was 30. I was to have a myomectomy, and during the myomectomy, they noticed, but the symptoms, yeah, there was intra-op that it was confirmed I had endometriosis. I've had like 2 rounds of Zoladex, that's a gonadotropin hormone-releasing hormone analog. I've had combined estrogen and progesterone pills for over a year. My quality of life has been like 0. I've had a supportive family, and that's why I've even been able to come this far. It's not been easy. Pretty much everything that all the panelists have said today, I've experienced like one thing or the other. I am currently doing a PhD in epidemiology, but I've been battling depression from pelvic pain, lower back pain, dysmenorrhea, menorrhagia. The list is almost endless. Then I have this chest pain, right-sided chest pain, right shoulder tip pain. It's crazy. It is crazy. There are times when I just have to go to my room and cry. There are times I'm in the hospital and I'm paying attention to my patients and I'm almost collapsing in the process because I haven't paid attention to myself. And like I said earlier, there was time I was in the A&E. I was doing A&E posting for 3 months. It was the most difficult time of my life because I had to look after people. I was going through a lot. I wasn't really giving much support from my coworkers because they didn't really understand what I was going through. And just as someone said, some people would even think you're malingering because you want to dodge work, but they don't get it. So it's really been crazy. I actually started residency in family medicine, but I had to put it on hold at some point. And now I'm to health insurance. I'm with the Kaduna State Contribute the Ministry of Health. And this is because of endometriosis and what I've been going through. Alongside the endometriosis, discovered I had uterine fibroids for so long. I think it made the fibroids get worse in my life. And everyone for making this meeting possible. Thank you so much. And thank you to Dr. Bayomi. Thank you so much.
Thank you very much for sharing. We greatly appreciate you, and I wish you good health. Again, those are tangible realities of women suffering from endometriosis. And I don't know about you, but it cuts me to the heart that everything practically paralyzes except the pain. I send my love to both of you and to every other person who's not unable to share, but who's there listening and joining in. Thank you very much. I have some more comments coming in and we'll be wrapping up in a few minutes. Let me see here. Okay, yeah, I agree that this needs to be more than once a year. Okay. Fatima Wakili was asking about diet that could be helpful. She wants to share, but I think if one of our panelists could briefly share so we can wrap up in about 4 minutes. Let me ask Dr. Oko to share with us diet changes that might be necessary or that might be helpful.
Thank you. There are cases where endometriosis has been linked to obesity. And there are cases where it has been said that the more exercise you do, the better, because you actually get more active as well. Release endorphins, which can help. Sorry, hold on. Release endorphins, which can help with mitigating depression and its effects. So a whole lot of things. But the truth is, if I'm being honest, in proper evidence-based practice, there is no single diet per se that people are going to say, oh, this is that miracle cure for endometriosis. So I think it is actually doing things in moderation, the things we already know, keeping an active lifestyle, more fruits and vegetables, and trying to reduce that BMI and the abdominal gait. Because even when we have to do interventions that could involve maybe laparoscopy or certain surgeries, being not that big or chubby or rounded, as I would say, is an advantage. Also in the infertility department, when we want to manage, we'll be requesting a particular BMI below 30, the minimum. So these are daily things we could actually do to help ourselves.
Thank you very much. And a final one from the chat box that we will be able to take from now. I'll send this to Dr. Ajayi and I'll make it double folded just so we can save some time. Bernard Iho, who is asking one of the doctors to speak about merging of organs caused by endometriosis. This person says she's a sufferer and symptoms are getting worse. Dr. Ajayi, merging of organs caused by endometriosis?
I think that should be adhesions. I'll leave that to Dr. Ajayi.
Is Dr. Ajayi here?
Oh, yeah, sorry, I was muted.
Okay.
Yes. Yeah, Loretta said it. I mean, it's additions. Because, we say that endometriosis is the endometrium in abnormal places. So it's like you are bleeding into the abdomen directly. Blood is not supposed to be in the abdomen. So what happens is that the blood that is released causes you the addition to form, or scar tissue to form. And this brings the organs together. So there is gumming of addition of the organs. And this is one of the reasons why they have pain, they have intercourse. So you can imagine when the organs are already gummed together and then somebody is trying to do something funny from below. That causes a lot of displacement of the organs and then there's pain. Yes, so that's quite common, and it also probably can explain some infertility that we have with the endometriosis. So that's not unusual.
All right.
Now,
finally, I would like you to speak about the Endometriosis Support Group, so that this can be a continuing conversation. How can people join?
Yes, the Endometriosis Support Group is there 365 days a year. And seriously, people can join anytime. And also, we actually have extended beyond Nigeria. Now we have the African Endometriosis Support Group, and we're actually going to have, God permitting, if COVID behaves better now, in June, we're going to have a live event where we're bringing other people, advocates from other parts of Africa together. It's part of the things, if you see me, I've been on the phone trying to, because some of those guys are talking to me from other parts of Africa. So we're going to have an event in June, and but you can join at any time, esgn.org. You can join at any time. And for Patricia also, if she's willing, we will want to help with her care if she's willing, and see what we can do.
I am very certain. I think I can speak on her behalf that she's very willing. She sounded really willing. So can you tell her how to reach out? Does she have to come to the facility or send a mail?
Oh yeah, she can send a mail. She can send a mail, and then we take it from there. It will be replied to, and then we take it from there.
Okay. So before we go, we have a dance video just to, I know it's been, I mean, I feel the pain of everyone who's shared, but before we wrap up, we want to play you an endo dance video. Like Dr. Jai jokingly said, years ago was difficult for a lot of people to even say endometriosis, so it was endo. So we're going to play you an endo dance video, after which you take the vote of thanks. Remember, the support group is always open, and we are encouraged to join in, okay? And to also invite other people that you know need all of that support. That's why the support group is here. So if we're ready for that video now. Thank you very much. That was quite a dance, so packed full with message. I hope it lightened up your heart a bit. Thank you, everybody, for joining. We'll wrap up now by taking the vote of thanks from Mr. Onora, if he's ready for us to give us a vote of thanks.
Yes. Wemimo, thank you very much. Thanks, everyone, for being a part of this wonderful event. I'd like to say a big thank you on behalf of Endometriosis Support Group Nigeria. I'd also like to make some quick remark for Halima. Halima, you say you're in Kaduna State, and I think it's good that you are someone who understands what has been the case with women like you. So I would like to also reach out to you so we could work with you to get the attention of the Kaduna State government, especially the governor, who seems to be someone who may understand what we're trying to do, and reach out to maybe the First Lady, and then we can build a number of things around increasing awareness. It's clear that women in Nigeria equally have this condition. Many years ago, it was thought that endometriosis was something for only white people, but today it's very obvious that Nigerian women are going through a lot, and we need to work at state level and then see how we can escalate it to the federal level. I'd like to thank everyone who has participated. Professor Michael, very, very grateful that you've been able to, at very short notice. We know that there are people on the Eagle Square in Abuja, so you've been able to fit in, and you really did a fantastic job. So thank you very much for that honor to be part of this. I'd like to thank Dr. Loretta also, Oko. Thank you very much. It was very exciting. Your presentation was spot on. And I'm sure you've inspired a lot more women, and I'm sure they will look forward to this. Dr. Bilkisu Kankia Lawal, thank you very much. Exciting presentation. And I would always like to say a big thank you to the elephant in the house, Dr. Abayami Ajayi. This journey, I'm sure, is about 15, 16 years now, and we're still going strong. It's just the tenacity of a person to be able to push on even when everything seems not to be right. For everyone who has attended this event, I'm extremely grateful, and we'll thank you for joining us. As we said, the African Endometriosis Support Group will be having another event in June. We will publicize it as planned, and please join us in all that we do. Thank you, and have a wonderful evening. Thank you very much.
Thank you very much. Thank you to all the participants. Let me also say thank you to all the panelists who joined me. Thank you for all those wonderful presentations. Let's keep the conversation going. For those asking about the support group, the website is in the chat box. It's esgn.org. esgn.org. So you can check there. You find the mail address to connect. Let's keep this conversation going up. A big thanks also to Nordica Centre for setting this up. The fire, let's keep the torch going on, passing on across the world. I'm certain I need to have this conversation on my radio show about endometriosis. I mean, listening to the live feedback, the comments it's just something. Thank you all for joining. That's the end of this hangout. It was indeed a hangout. Like I said, when we began, is an educative hangout, and we'll join hands together and continue passing the torch up ahead. My name is Wemimo Adiwuni. I'm a broadcaster. I think you should listen to me because I talk about women issues on radio on Nigeria Info. Thank you, everybody. Have a fantastic evening. Goodbye.